or until no gurgling sound can be heard, thus exerting the minimal pressure possible onto the tracheal mucosa. One practitioner gradually inflates in 0.2 mm increments until no sounds are audible. They gradually deflate until breath sounds are heard again, and then slowly re-inflate until the gurgling ceases. The second practitioner uses a stethoscope, placing the diaphragm at the patient's throat to simultaneously listen for when the gurgling has ceased. It is good practice to measure cuff inflation pressures using a hand pressure gauge. Attach the gauge to the pilot balloon, depressing the one-way valve. Note the pressure displayed on the gauge, remove and record this. Pressure should not exceed the capillary occlusion pressure of 25 mm of mercury. Overinflation can lead to necrosis and mucosal erosion. A cuff inflated to less than this will reduce these risks. However, an under-deflated cuff may result in cuff leaks, aspiration and reduced tidal volumes as air escapes around the cuff. Wipe the gauge with a soapy cloth and dry thoroughly between each use to reduce the risk of cross-infection. If you experience difficulties with passing the new tube, try to rotate it slightly and re-attempt, or insert the tracheal dilators and attempt to reinsert the first tube. If this fails, remain calm. There may be swelling in the airway. Ask your partner to prepare the second, smaller tube. Reassure the patient at this time. Insert the second tube and inflate the cuff as described. During any delay, administer oxygen via the stoma to enrich the patient's oxygen status. If the second tube insertion fails and the patient is breathing satisfactorily via the stoma, continue to administer oxygen whilst awaiting specialist assistance. You may try to suction directly into the stoma to relieve any possible obstruction. To avoid tube misplacement, tube exchange can be assisted by the use of a tube exchange device or by using a tube and guide wire system. Insert 10 cm of the wire, J-tip first, into the indwelling tube. Pass the old tube over the wire, leaving the guide wire in the trachea. Pass the new tube over the guide wire, threading the wire through the obturator. Remove the obturator and wire. The new tube should be in place. Check airflow and respiratory status. Inflate the cuff and secure the tube as previously described. If the patient stops breathing at any time during the procedure, call for help. Lay the patient flat, occlude the stoma, and hand ventilate the patient via a face mask and ambibag or rebreathe system. Use 100% oxygen and proceed to basic life support if necessary. For laryngectomy patients, resuscitation can be performed via a masked stoma until a cuffed tracheostomy tube with a 15 mm connector can be inserted and hand ventilation can take place. Patients can have the tracheostomy tube manipulated for them to achieve a voice with the use of cuff deflation, one-way speaking valves and fenestrated tubes. Using a fenestrated tube improves airflow to the larynx, which will help the patient to vocalise, although it is possible to use a speaking valve on a non-fenestrated tube for short periods.